So how are things in Ahmedabad?
Good, yes.
Improved.
Almost, yeah, not no new report. There are some cases, yes,
Okay.
but it looks like Kerala is still.
It has still not come out. Right? Even now,
Yes,
the municipality that I am in is also in a pretty bad shape. Even we
Oh,
got,
oh.
you know that, right?
Yes, that is what I was worried.
So
How it is like.
just one day of outing got this, and that also she had gone to college for rectifying her certificates, and this is the situation.
Now my universities are like calling everybody full swing. I mean, everybody has to come entire day week. So we are going. We are going to office every day now.
Okay.
I don't know where it will lead to, but
so even I had 2 exam duties on 28th and 29th, so I was also out for that. So unless and until for these things, otherwise we are just indoors only, but still can't help, right?
I know.
So
Very bad situation is still not improving.
Ajit is also likely to join, so I had asked him, requested him to join. Maybe he'll also be there in quite some time, right?
Okay, yeah. But
So
if you are expecting somebody, then we can wait, or else we can start now.
no, we'll start because normally that is what we have been doing. We have been starting right on time, right, and then proceeding with people will keep on joining. I'll keep admitting them. So as such, there will not be any. I think just check whether you are able to share your screen. That's the only thing that I need to check.
Yes. Let me
Right.
see this.
Right.
Screen.
Then I'll ask. Yes, it is coming.
Can you see that?
Yeah, I can see your Zoom screen only, right? Yes.
Now?
Presentation is visible now. So
yeah.
Let me ask my student to start then. Right.
Yeah. Okay. Should I stop right now or let it continue?
No. Let it be there. Let that screen be there. That is good now.
Okay.
Right.
Okay. Fine.
Okay. So Aishwarya, you can start.
Okay, sir. Good evening to all and welcome to Emerging Discourses in Geography webinar series. This is the 5th webinar in the series on pandemic and urban planning. As COVID-19 has completely curtailed the offline classes, this is an initiative of Department of Geography at Government College Chittoor, Palakkad, Kerala to create research awareness among the students through webinar series. One of the best way to expose them to interdisciplinary research and also to guide them for their higher studies and career opportunities. The webinar is organized on all Saturdays 5 to 7 p.m. with about 100 plus participants in both Zoom platform and Facebook Live. The participants include students of UG, PG and research programs in geography from across the country. We also have faculty of geography and other disciplines and also professionals from various institutions as participants. I would like to take this opportunity to welcome the resource person for today's webinar, Dr. Anil Kumar Roy, Associate Professor at Central for Environmental Planning and Technology, University, Ahmedabad. I also take this opportunity to welcome all the faculty members and students of Department of Geography, Government College Chittoor. I also welcome faculty members, professionals, research scholars, students, and faculty from various universities, institutions, colleges, and organizations from India and abroad. Welcome to one and all once again. Now, let me welcome my friend, Ms. Suparna, to introduce today's resource person to you. Thank you.
Good evening to all. We have an expert resource person today, Professor Anil Kumar Roy, with over 20 years of experience. He is an associate professor at Center for Environmental Planning and Technology, University, Ahmedabad. He holds a PhD degree in urban geography from JNU New Delhi, and has studied urban and regional planning at Center for Environmental Planning and Technology, University. Dr. Roy was awarded a Canadian Studies Doctoral Fellowship for his PhD and was affiliated with Dalhousie University, Halifax in Canada in the year 2002. He had also worked for the UNESCO office in the New Delhi as National Coordinator for the Indian Heritage Cities Network program before joining Center for Environmental Planning and Technology, University in the year 2009. His research papers have been published in national and international journals. He has published 2 books and is currently working on another one on planning education in the Global South. Some of his research interests are urbanization in South Asia, Himalayan urbanism, environment and urbanization linkages, and urban informalities. So we can sum up that we are getting an extreme and honorable guest in front of us. So let me call upon Dr. Anil Kumar sir to start the session. Please, sir.
Thank you, Suparna. That was a very generous introduction. I don't deserve all those things. These are all naturally came up in my way. And me and Professor Govindan Kutty share that UNESCO heritage, experience. After me, he joined and he took it forward. So that's a connect, and I'm happy to be with this, gathering here. Online, of course, I would have been very happy if it would have been done, in campus. And Kerala, anyway, is always my favorite place to visit. So thank you very much, Professor Govindan, to invite me and the student community. It is a pleasure to be with you this evening. Yeah, I'm just trying to, understand the pandemic and urban planning synergy, or I call it the linkages or relationship, how it comes out based on the, particularly last 2 years, 1.5 years experience of world pandemic, and also India suffering a lot. And therefore, we're trying to, understand it both as an urban professional, as a researcher, or also as a common people, to what could be the, the contribution from urban planning side, and also urban geographers particularly, to deal with this kind of pandemic. So let me begin with the understanding of pandemic first, and then I'll come back to urban planning and its related aspects, and how it could be a kind of a intervention that can minimize the negative impact of a pandemic in an urban setup. So that would be my intention. And recently, I have guided one of my students from Kerala. She has studied Trivandrum as far as health infrastructure and urban planning is concerned. So we'll have largely discussion on that case study also, Trivandrum as a case, and how urban planning and research can help in understanding the pandemic, and suggesting some few doable actions that is required from urban planning. So let me go ahead with this presentation. Can you all hear me and see my slides?
Yeah,
All
yeah.
visible?
Yeah.
Okay. So let me try to just recapitulate. Everybody know now what is pandemic and urban planning also to some extent. But let me reiterate here once again. Sorry, I can't move. Okay. So this pandemic is a global phenomenon. When like as per the WHO definition, when any disease which is not previously known, very new to the medical science, and there's not much cure about it, and it spreads more than 3 country region of WHO, and WHO country region is even country 182 country, maybe more than that. so that they declare it as a pandemic. Epidemic are also kind of a large spread infection of any diseases, whether it is virus or any other. But generally, these pandemics are of global nature. So therefore, we should understand when it becomes pandemic, that means it's a global phenomena. It is everywhere. And then I started looking at what has been the history of this pandemic, particularly while last century. We could not go beyond that. This is my lack of research, but let's understand. And these are some of them, like 8 of them, major one that has happened in last century. The first one was the biggest one, where almost 100 million people died. So these within bracket figures are the death and their year of occurrence. So 1918 and 1922 years. This is Spanish flu also, but we have avoided because WHO, and it's not a good idea to name the pandemic based on the origin of the country. Therefore, this is a standard practice. So this is by the nature of virus, and therefore the name has been arrived. And we have the biggest one in exactly almost 100 years before. And then after 50 years, we had flu pandemic again. That was H1N1. This was N1, N2, H2N2. 1 million there also. Just 50 years before, we lost 1 million. So again, in 68, 69, 1 million. Again, flu pandemic. Almost nature of the virus was same. Then there was SARS, where it was kind of less lethal, we can say. Then swine flu happened, and then MERS-CoV, which is that Arabian country suffered, and then Ebola, recent one, which was like very much known in the world in recent time. Ebola experiences have helped some of the countries to be prepared for this pandemic, and this is ongoing COVID-19. SARS-CoV-2, which is like 4 million we have already lost. It is ongoing. We don't know how much, but it is a pandemic situation currently the world is facing. So moving on to these historical dimensions, let's understand the current. This is as recent as it could be. I think it is around afternoon data. So you can understand 18 crore already suffered, and then 16 crore has recovered. But this death figure is 40 million death all across the world, and 4 million in India. So that is the worrisome, not 4 million, 4 million in the world, and 4 lakh in India. That's a figure that we have. So this is a huge, human problem in terms of pandemic. I've just tried to correlate it. I've not done correlation, but I've just tried to link how urbanization is associated with particular this pandemic. And this is what it comes. What I did is quickly that I went to the top 10 countries in terms of the cases they are having, the total cases. So ranking of these countries based on the total cases, not their population. So these total cases, top 10 countries, if you look at, and if you look at their levels of urbanization, barring India, all of them are better than world level urbanization, which is 55% of the total world is urban. And you look at it, and all these 10 countries come from primarily, North America, of course, USA, South America, and Europe, and India here. None of the least urbanized regions are figuring in this top 10. The major finding of this data is that the total cases of the world, 65%, almost 65% of the total cases of world belongs to this 10 countries. 57%, 58% of the total deaths belong to these 10 countries, and serious illness, 50% of the serious illness are from these 10 countries. So this is my recent finding. This data is as latest as it could be, 30th June 2021. So what I'm trying to infer from this data is that it is an urban issue. It is the factor of urbanization. I'm not saying it is the cause of urbanization, but it is related to urban settlement. And therefore, we need to focus, and it is concentrated. You can identify them where they are there in intensity. And this reported death, I'm just trying to come back to India now. This is little early stages of COVID pandemic that is happening in India. That was happening, this is as of October 2020. And if you look at the fatality deaths during that time, it is on October 2nd, this map of India showing. And these are the major clusters of death, which is, Delhi, Mumbai, Kolkata, Madras. So straight away correlation can be made that these metropolitan cities were the major point of contact from the world, and therefore this is a kind of pandemic which is happening. And therefore these rural urban thing are now, we have now rural also. And if you look at the districts affected, top 10 districts, Mumbai, Pune, Thane, Chennai, Bangalore, Nagpur, Ahmedabad, Kolkata, Kolhapur. I mean, if you look at these top 10, these are the most urbanized districts in India. So that's the idea that I'm bringing, that it is an urban phenomena. And this was the early, and this is one of the best, early research which has been done by the geographer from Aligarh Muslim University. And this is the team here. Sorry, this is the team they have done. Initially, they have identified the hotspots of India as early as August 2020. And they have identified these. Look at these cities. Delhi region, Agra, Jaipur, South, we have many cities, you have North, and then in Calcutta and Bhubaneswar. These were early hotspots of the country, and this was mapped. Therefore, the role of geography and city becomes very important. This is very current, this is ongoing, and if you can see the states suffering from this COVID-19, 5 days moving average, this is already there. I have not done anything. This is, I'm using Ministry of Health and Family Welfare and John Hopkins data. So Maharashtra, Karnataka, these 11 states are top, is still reporting, top states reporting the COVID cases. Peak was in May 10 to July 1st, June it started coming down, and we are July 3rd today. So there is some downward trends that the figure is improving, the COVID cases is improving. This is, I'm again taking the same data for cities or districts. This is districts, and these districts are almost 90% urbanized. If you look at these districts, except 24th Pargana or Ernakulam, and Ernakulam also, if you look at Ernakulam, it's more than 90% urban. So these are all urban phenomena still, having, and this was the peak. April and June was the peak. So this is how I'm trying to hastily make a relationship that it is the urban area, it is the process of urbanization that pandemic has been challenging the cities and urban professionals. So therefore the urbanization, health, and the role of urban planning is very crucial here. I would say, and therefore health, WHO has identified urbanization as one of the key challenges for public health. Why? Because the overcrowding, high density settlements, lack of public and open spaces, etc., are the major issues of urban planning. We've not been able to manage the influx of the population coming to urban area. The developed country has done already, but there is also a problem of close proximity, sharing the common spaces together in terms of city dwellings. Health promotion efforts grounded in a healthy city approach can contribute to achieving the sustainable development. And that's what we thought that we'll also, if we have to achieve this SDG goal number 11, making cities and human settlements inclusive, safe, resilient, and sustainable, health becomes the priority. And particularly this learning of last 2 years almost is very paramount in this discourse. And therefore, I would venture upon this particular area. So why it is an urban challenge then? So data already says that, yes, it is going to be urban phenomena. By and large, the rural hinterlands are, but in second wave, we did experience the rural hinterlands also coming in the wave of pandemic. But why urban challenge by and large? Because it spreads human to human contact, and therefore the urban high density settlements where people live, work, and play in close proximity, and therefore it is very dangerous in that particular settlement because it contacts fast and it spreads very fast. Informal settlements generally have high density and poor health infrastructure, and therefore the cities are vulnerable to this pandemic. Urban community have more common and shared public spaces. I was telling you, you see transport, public transport, if you say, the city centers, the other public utilities, parks and gardens are all shared spaces. And therefore, the pandemic can be much more dangerous, much more fast spreading, and therefore the role of planners has to be identified. Urban dwellers have also global mobility. If you look at the city to city contacts rather than city to hinterland contacts are much more. So therefore, this can be one of the major challenges also. Cities, and particularly big cities, do have better in terms of better facility in terms of health infrastructure, and hence they can be overwhelmed during the time of pandemic, and that's going to be a major challenge. And therefore people were advising stay home and a home quarantine and other things because the health facilities were overwhelmed. Cities are also expected to ensure better living conditions in normal time and during this new normal. So it all becomes urban challenges while we are facing this pandemic. I've quickly done this mapping in Ahmedabad. This is as early as 1st of April 2020, when the lockdown just started. And if you can look at the initial cases reported in Ahmedabad, and we could provide the containment zone during that particular time, having 1 kilometer buffer area. And you can see these overlaps here in the old city area, the major concentration of and then the western part of little influence area also having COVID cases. Because of the Western influence, people came from different parts of the world and they brought these diseases. So therefore, I'm saying that, yes, there are many things establishing the link of COVID-19 pandemic and also the urban planning synergies that need to be done. And this one later on, 19th of April, I was like trying to understand the spread. And if you, the darkest shade is more than ward level, more than 30 patients. And then we tried to have this kind of, idea emerging in our initial analysis that there are two sides of the same coin: high-rise high density in Western India, Western Ahmedabad, and low-rise high density. High density was common between these two parts of Ahmedabad, and therefore, if you look at the cases there, the eastern part of high density area where informal settlements are much more, we have much more cases there. But general later on, it didn't hold true. And we have also mapped the health infrastructure in Ahmedabad. This is latest one of my students' thesis. I was guide. Therefore, if you look at the eastern western Ahmedabad, there are fairly good amount of the violet color are the private hospitals, the red ones are the government hospitals and other PHCs and UHCs. So therefore, health infrastructure facilities and the COVID patients where almost looks like we have facility, but there were problems of accessibility of these. So there I would rather, when I come back to the cases of Trivandrum, I'll talk about the accessibility issue while dealing with pandemic through urban planning challenges. And therefore, can public health becomes a focal point for urban planning as a profession. And I do agree that why not? Because if you look at the hesitancy of private health facilities coming in front while we are facing initial stage of pandemic, all hospitals were shut down. And that was, one of the biggest challenges in the city. Only the public hospitals were open. The public health professionals were open for the services, and there were lots of chaos in that. So therefore, the public health infrastructure and services becomes key in the urban planning scenario. So therefore, that synergy in handling, you can't do away with either or. You need to have both of them together, but how to facilitate them to work together was a bigger challenges, and therefore urban planning can come in a handy, because they can therefore identify the location of public and private infrastructure, hospitals, beds, and things like that, and they can also distribute the facilities between these two service providers and tell the city government that one can utilize both the services. So these are the idea of urban planning that needs to be understood by all of us. And therefore, I quickly pointed out that providing supports in a spatial distribution of public-private facilities is the role of urban planner, and how do you make them accessible to each of the community, either at the neighborhood level or zonal or at the city level. And therefore, identifying the shortest route for easy access to the hospital facilities, reducing the travel distance during the COVID time. So this is how I would bring this argument that yes, of course, there is a role of urban planning in handling the pandemic, but by and large, if we argue with our fellow professionals that health is not the prime concern of urban planning, it is we just deal with the allocation of various lands into different uses, and therefore it is a challenge to bring health also in the purview of urban planning. But if you look at the challenges and issues, it relates that it is evident that the health can be part of this particular planning processes. Moving on to this planning and pandemic and case study. This is going to be a little lengthy, but I would try to cut short some of the slides and move on, so that our discussions becomes quite fruitful at the end of this particular slides. This is what Trivandrum case study. 100 words, as some of you must be knowing or belong to Trivandrum. Correct me if I'm wrong. Somewhere the data collection has been done online. Therefore, I can't guarantee the accuracy of the data, but this is a survey data we have done, through online. Sitting in Ahmedabad or Delhi, my student was sitting in Delhi. She could not able to reach Trivandrum. All online survey have been done, so that's the limitation. But still, we can infer some of the real findings, some of the crucial finding of urban planning and health infrastructure relationship. So moving on to this key inferences, health infrastructure facility, if you look at in Trivandrum, you know, these are all health infrastructure from private and public put together. And if you superimpose it on the density map, population map, you can see the concentration of the health infrastructure and density and populations are in the central part of the city. Peripheral areas are, yes, of course, less density also, but also having low levels of, health infrastructure. So this is how high population zone area have a higher infrastructure facility. 130 health institution. We're calling health institution because it includes both what we call public and private hospitals. So, and these are the numbers. There are 1 general hospital, 1 district hospital. I'm not going to list down all those things. The best part is that there are 28 hospitals and 3,000, almost 2,915 beds available for Trivandrum, which is, in fact, we'll argue whether it is less or more, but let's see, as per the standard planning standards, whether it is more or less in that sense. So this is how we did this particular analysis here. Hospital beds and doctors, generally doctors are, calculated on the basis of per 10,000 population, but WHO does not provide any of these standards. So therefore, let's not bother too much on that standardized things, normative things. But what it is, therefore, if you look at Trivandrum, Kerala, India, and worldwide, I think in terms of public hospitals and total hospitals, if you look at the total hospitals, Trivandrum is fairly good position, better than world average, and also, of course, far better than India and Kerala average. And therefore, if you look at the doctor per 1,000 population, both public and private together, the Trivandrum fares almost better than Kerala and India, but not at the global level. Global level needs 1.7 doctors or almost 2 doctors per 1,000 population. We don't have even in Trivandrum, one of the better health infrastructure, health services states. But if you look at these nitty-gritties, we are not there. So therefore, we need to improve. India anyway is far behind in terms of doctors per 1,000 population. So let's see what happens in the other health infrastructure. So beds, here in Trivandrum, government and private put together, the 11% of the total Kerala's beds are there in Trivandrum. ICU is far better in terms of government and private put together, 11% again, and ventilators also 12% of the ventilators of entire Kerala is in Trivandrum. So if you look at this facility in itself looks quite okay, but nonetheless, hospitals in Trivandrum of late, I'm aware that they have been overwhelmed. There are lack of facilities and services there still. This is how COVID care centers, 1,600, medical professional 2,670, and non-medical staffs to support is almost less than the medical staff. That's the skewed, ratio. The non-medical staff should be much more than the medical staff to support them. And therefore, I found this particular gap. I don't know. I'm not in this hospital management field, but we need to have understanding. These 2 major findings for urban planning is very relevant as far as pandemic is concerned. The 2 key findings, one is that almost 80% of the total Trivandrum populations were having COVID care hospitals within 5 kilometers of radius. And 67% of the people were having, one vaccination center within 5 kilometer radius. So that looks like quite a better, in the city dwelling, 5 kilometers, if you're walking, it's not possible. You still need, transport system to go to reach to your COVID hospital and vaccination center. You can't manage without the vehicle. So whether it is public or private, there is another role of transport, urban transport system in accessing these particular facilities. This is what the latest Trivandrum data while we were doing the research, 12th March 2021, latest data shows that, okay, recovery rate in Trivandrum is 97%, Kerala is 96%. So therefore, if you look at these peak, March, April, May was peak. So before the peak started, this was the death figures in below 1,000, active cases. And this is also, so the confirmed cases were very much there. And therefore, till then, this is cumulative figure. So some hospital managements and better healthcare infrastructure resulted in this kind of comparatively lower death rates. We reached to the hospital staffs and doctors, nurses, paramedical staffs we included. There were 12 who responded our online questionnaire, and therefore these are some of their understanding about the health care facilities which they were able to handle. So that they were saying that this was but their experiences were quite high. If you look at the more than 10 years experiences, it is around 63% of them were having more than 10 years of experiences, and much more younger. I mean, between the middle-aged group were much more there in terms of providing the facilities. Their working hours have increased, up to 4 hours. So that's an issue there. They were overtime, 8 hours anyway usually, but they were almost working, half a day, 12 hours per day. That was their concern. They got the training also in these things. They were also, because this particular pandemic is very new, therefore they needed the training, and they got this training in critical care related protocol, sanitization protocol, general hospital procedures, and all those things. So critical care related protocol where 30% training, the hospital and other management training was also provided to the doctors. Safety of the health workers were also important, and therefore vaccination received. So almost 73% frontline workers, these doctors were all vaccinated at least once till the survey was done, I think in March 2021. And these were their safety gears provided, telemedicine, PPE, and all these things were provided to them. Major finding here was the supply side actors, the doctors, nurses, paramedics, do have experienced the insufficiency of these things, particularly ventilators, ICUs, COVID testing. Nurses also were less because they have to do overtime, and non-paramedical staffs were. That's how I was telling the figure of cumulative figures of medical staff versus non-medical staffs. And therefore, these were concerned. If you look at the satisfaction level, working hours, infrastructure as hospital, these blue lines are the concern, because the satisfaction levels there is very low or average below 3, or some of them have 4 scale up to 5 on the 5 scale. And therefore, if we come back to then the demand side actors, that those who were accessing the hospitals, it may not be the COVID patient, but their relatives and all, they responded, and therefore some of the vital questions were put forth to them, and they were giving us the answers. So 49 almost, we did not do 50, but 49 people responded, and they were like, if you look at the Kerala education level is anywhere high, all section of the society, Hindu, Muslim, Christians, the number of members in households, if you look at that, 60% or 3 to 4, 65%. Annual household incomes were, middle income group 6 to 8 lakhs were majority, 50% were having 6 to 8 lakh 8 lakh annual income with 3 to 4 people in their house. Therefore, if we ask them whether they have choice to go to either public or private institution, majority of them choose to go to government institution. That's the biggest finding of Kerala, particularly Trivandrum. Although they can afford to go to private hospitals, but they did prefer to go to government hospitals. That's the thing. And if you look at here, in income group wise and age group wise distribution of access to choice of the facilities, look at these, government hospitals, all the respondents were preferring, even the high income groups, only the highest income group people preferred to go to, private hospital than the government hospital. Rest others prefer to. Age-wise is very interesting, None of the 60 plus respondent opted for private healthcare facility during the COVID. And that's important aspects of, health management system in Kerala and in Trivandrum particularly. And look at these other age groups, all of them preferring more to go to public institutions rather than private institutions. And this choice of hospital for COVID care, if you look at the type of hospital, is still government 70%, 30%, and the distance, within 5 kilometer, majority of them were having 5 kilometer distance. And then 5 to 10 kilometer were also, but within 10 kilometers, where all respondents were having that access to COVID care systems. Vaccination is a major part of this pandemic. It has to be fought with this vaccination. Therefore, if you look at the public-private hospital doing vaccination, still government is still dominating. Yes, concern about vaccination was also there. There were 10% were concerned, but 90% people being educated and much more, health infrastructure facilities there in Kerala. By and large, there not much hesitancy in COVID vaccination. So this is how the some of these concerns were unknown side effects and how effective this vaccine usually actually is, and would there be any complication as a result. This is the common hesitancy issues across the board. Either you live in global north and global south, these are the questions being put forward as far as in vaccination hesitancy is concerned. The overall experiences of the respondents, if you look at the need for improvement, bad was not been responded by any of the respondents. Need for improvement, if you look at the need for improvement for private hospitals, need for improvement for private as far as these are COVID testing protocol, infrastructure at the hospitals, the behavior of the doctors, satisfactory for all the government hospitals, satisfactory for all the government hospitals as far as behavior of the paramedical staffs are concerned. So, 3-4 places we had the issues coming up from the respondent sides. And some of the findings and concern, if I have to share with you all, these are the only 23 hospitals providing COVID care, concentrated in the city center. Peripheral areas were having less COVID center facility. Therefore, they have much more travel distance to travel and avail their, in the lockdown, it was an issue, and therefore, more private hospitals, but less infrastructure, beds, ICU, ventilators, more in public hospitals. Dependency on public hospitals much more higher. Non-medical staff shortage was also there. The overburdened staffs doing 2 shifts, in a day, and secondary data was not visible there. Early days frontline coverage of vaccinations, workers needed to be given priority, but still there were only 76% medical staffs getting vaccinated because they are also at risk. Sorry. And then health infrastructure shortage also was a concern in some of these public and private hospitals, as we witnessed. And therefore, 19 hospitals here we need to increase. Therefore, suggestion for health authority, more choices of hospital for patients should be there. Reduce the burden of existing hospitals, allow private hospitals to test COVID, also provide vaccinations. So that was there. Focus on frontline workers, more awareness about benefits of the vaccines, increase in human resources, of course, that is required, and more beds, oxygen cylinders, ventilators, and more investment into the health sectors. That was the larger, concern because hospitals were overwhelmed within that survey period of time. And we are not aware now what would have gone wrong during April and May, which was the peak of India's second wave. So I think things would have been tackled properly and could have been better. But this is the indication of the early survey. For ULB, this particular study suggests that they should understand the local context because they were not going into the neighborhood, issues of close proximity for healthcare, COVID healthcare, or close proximity for vaccinations. They were just wherever they had the facility, they started doing vaccination, irrespective of the distance people travel, irrespective of the public transport system being operated or not. So this was the immediate, concern and suggestions to the ULBs, particularly the Municipal Corporation of Trivandrum. More vaccination clusters was required within the proximity of 1 kilometer or 2 kilometers. Lesser travel that will result in more vaccination, and we focus that there has to be a special planning where accessibility of healthcare system would be ensured through GIS mapping and other systems, cantonment zone and vaccination centers and COVID healthcare facilities has to be identified, mapped, and given a proper accessibility plan to them. This has to be managed as a disaster, and of course on paper, because all the COVID services were put under this Disease Prevention Act of 1857. Therefore, this was there, but in practice, we found that there is some kind of a lethargy in ensuring it, the delivery of health system in this particular second wave, particularly. Guidance to ULB and the health departments to include, urban planning services along with the health services. Therefore, it becomes a joint efforts of urban planner and urban administrators. So that was the major findings from the case study that we did, and therefore, the global slogan, which is there, health for all and all for health, which is WHO also suggesting that healthy city. So there has to be a paradigm shift from, economic cities are economic engines of economic growth, but it should be also a place for healthy life. And therefore, if you are not including health as a priority concern in urban planning in the city particularly, we are losing that particular slogan, and it will be very difficult to particularly address the issue of health for all, which is SDG 3 and then SDG 11, which is of course safe, inclusive, and sustainable cities. And therefore, this paradigm shift has to be addressed through various actors in the city. And then planners' role becomes paramount in that particular thing. And therefore, the healthy city requires that municipal government understand health threats and map epidemics, measures or estimate the health impacts, both positive and negatives of the developmental activities, which is very much complex analysis. And therefore, the evidence-backed interventions and monitoring and evaluate the impacts of health equity in the development. So that's the major, concern, I would say, and we should propagate that there should be a major role of urban geography, urban planning in case the pandemic hits. And therefore, last but not the least, I would say urban planning professionals, should be now, gearing towards new kinds of technological transformation. And these 4 or 5 points comes in my mind. I have not done major research work on this, but this is suggestive. So from master plan to community and health planning has to be ensured in the exercise of urban planning professionals. Use of big data. If you don't have big data, you can't estimate, you can't do anything on real-time basis, and therefore remote sensing and big data, GIS, both in theory and practice has to be promoted. In case of pandemic or beyond, use of artificial intelligence in model building and design, that is very much important. And the use of new technologies are anyways going to be there and coming up. The irony is that right now this particular disease pandemic has no cure. There are prevention, and that prevention is, if you look at these major preventions of social distancing, which we are new norm, social distancing, hand hygiene, and masking, face mask when you are in open public places. These 3 things, if you look at it, and therefore a question of food security is also, if you are in-house when there is a lockdown, the food security issue becomes paramount, and therefore urban planning comes in picture, the supply of essential goods. If you don't have urban logistics in your city in place, I don't think you'll be able to, deal with any kind of disasters, any kind of pandemic, which is now in operation. So I will end it over here. And if there are questions, I would be very happy to, answer them here. Thank you very much for listening.
Yeah, fantastic analysis and presentation. The session is open for discussion, questions, etc. So those who have questions, they can unmute and ask.
Should I stop the sharing so that we can have one?
So does our MOHF have any criteria for number of health centers per maybe per population size or per ward or something like that?
Yes. There is this thing, particularly this guideline for PHCs and UHCs are there. Every 20,000 population, 1 PHC is prescribed in urban center, and any 30,000 population, any hilly region, it's 20,000 population. So it depends on the catchment area of the population, and there has to be, which is like, and also there's a distance criteria, So that distance criteria is quite vague, because then the population threshold and distance cannot match. So that's how. But in an aggregate, if it is at zonal level, you calculate the population and provide the similar amount of PHCs in one zone. At least that planner can do that. If you have a eastern, western zone or 5-6 zone in your city, and you calculate the population and provide the facilities within that approximate distance of 2 to 4 kilometers, that's okay in an urban setup. So that's there. Yes, but, the standardizations are there.
Yeah. What about then informal settlements? Informal settlements may not have such a facility at all, because government may not be ready to put up a PHC in a place where the land is not there, it's either private or no, such kind of issues are there. I have seen that in Kandivali ward, in both the Kandivali wards in Bombay. I think in RS, I'm forgetting the name, 2 or 3 wards in Mumbai, which I had surveyed sometime in 2003-4 period.
Yes. That is, Govindan, this is a kind of, then the politics come in picture, then you try to decision makers try to take their discretionary authority and they say, oh, I don't have land there and this and that, so many excuses. But if you follow the norm, if you do that, little bit of spatial analysis, which that urban planner should convince, and you may find some of the places. Therefore, I give one of the examples in Ahmedabad when they were doing slum networking programs. In the program itself, there was inbuilt, provision of healthcare facility. So if you are revamping the houses of the poor, in a cluster of 200 families, there has to be one PHCs. So you have to find out through community. If you don't find the spaces on your own, go and meet the community. They might give you some shared open spaces, which they have common spaces, and there we can facilitate. So, but then the problem is that, how much participatory planning in India is done. And that's a big question. And therefore, the neighborhood level, we need to have community planning and health planning together. Otherwise, health is, at present, is separated from urban planning. Departments are also there, but municipal ULBs are slowly withdrawing from the provisions of health facilities within cities. Yeah.
Anyone has any questions, they can put forth questions, unmute and ask. Now, in 2007, there was, I think it was our Manmohan Singh government, which had brought out a health document for entire India, right? I think Urban Health Mission, right? So what's the status of it as of now, right?
That has been completely put in dock. I don't see anything which is purely on urban health. Health for all, yes, slogan is done. And therefore, states have been asked to provide, health facility through public-private partnerships. So therefore, the withdrawal nature of government from health sectors is a concern, Govi. Because and then if you look at the
I was part of that when I was with UHRC. I was doing that mapping.
Yes. I remember. Yeah, I remember that. So there is nothing called Urban Health Mission.
Yes.
If you look at, there has to be something called. It has come. Swachh Bharat Mission Urban and Swachh Bharat Mission Rural. But we are not going beyond that. You're assuming that, if you provide sanitation and hygiene, health improvement is paramount, or it's automatic, which is not in some cases, There has to be an health interventions.
Now our urban planning has been something like investing too much on infrastructure, right? Be it transport infrastructure like MRTS and such kind of things. And you can see all of them have been, in a shutdown condition for long period. And what do you think? Will these modes of transport be there in the future or will decline? Because people will prefer traveling in their own vehicle, for the sake of safety, right?
Yes, of course. No, there are some of the resilient recovery, studies are being done are in progress for transport resilience recovery. The entire, system need to change because you need to put more facility into action. Therefore, that social distancing has to be maintained within public transport system itself, at the terminal level or within the mode of vehicle that you are proposing. But that's one of the challenge. Second challenge, of course, the demand for private transport system will increase because everybody will prefer to move either on their own bicycle or on their mobike or car. So, and car is going to be, because there is an incentive on car buying in India, so it is going to dominate. So there is another challenge of transport traffic that is going to happen in the normal time. Of course, if you're locked down, there's no issue, but in the normal time, more. Therefore, look at the recently, day before yesterday, all the car manufacturers, two-wheelers have increased the prices of their, products. So therefore, there is demand of private vehicles.
Yes.
So how we deal with them is another challenges. And in some of my previous understanding, and we were all thinking that lockdown has helped in cleaning the air of the cities because the less pollutions are there. But that's temporary. That's not going to be a permanent feature, because society will rebounds and compensate the losses that have been occurred in economic terms. So we'll put more efforts to compensate, and that's the history. After each pandemic, there would be much more pollution, much more demand for consumer durables and everything. So that is going to be there here after this hopefully ends.
So I think someone has posted something maybe.
Yes, I can read that. Parvati, yes, very good question. Yeah. So yes, I agree with you completely, because first is that if you ensure sufficient amount of public spending on health, that means you can ensure the infrastructure and services. That is not happening. We are just relying on private investment, and how this private investment was their hand during the initial stage of pandemic. So therefore that danger is going to be there. And therefore, the countries, particularly, I did not mention here, South Korea and also our Kerala studies, it's still better, Trivandrum, I've just highlighted the, shortcomings, but compared to other cities, compared to Ahmedabad, I don't have that comparative figure, but this is my perception, it's much more better, because the reliance on public health system is much better. And therefore, we could save many lives and provide a good care system. So Korea is one of the examples where public health systems are very much under control, and there is sufficient expenditure on public health facility. And therefore, I put this in the abstract also, this public health system is going to be the crucial one during this kind of pandemic, because then everything fails, then it's only the government system that operates to rescue people, relief operations, and also post-pandemic care. So we need to be very careful in choosing this balance between public and private systems. But urban planning cannot ignore either of these two. Planning in isolation is not possible. We can't plan only for private, public goods. And there has to be, the public goods also includes the providers, service providers from private sectors. And therefore, there is a role of, private partners in planning. So I think, and classic example, I'm not great fan of Kejriwal, but Delhi, if you look at, their neighborhood health, first contact, of health, they call it Mohalla Clinic, and that's what that partly answer Professor Govindan's question also. They have penetrated to informal settlements also. That's a big thing, and therefore at least first contact, immediate action to be provided for preventive diseases. So therefore there's some kind of relief for immediate suffering, and they can come to the bigger hospital, a specialized hospital later on if they have a chronic disease. And that will be a very good system for prevention of the outbreak of some of these contagious diseases, because they are treated then and there. So I think, and they're increasing the budget also for health infrastructure and health facilities. We need to take a national decision, because still the national government is not allocating. There is a total demand of, at least 2% or 3% of GDP on health. It is not happening. It is still 1%, maybe 1.5% right now. So that's the major issue from there down to bottom, at ULB level. ULBs, by the time they come on health sector, they are exhausted with their budgets. 50%, 60% of the ULB budget goes into salaries, So ULBs are resource crunch, barring few like Mumbai Municipal Corporation, Ahmedabad Municipal Corporation, they are surplus. They are unable to spend money. Still, they are not investing in healthcare system. That's the worry. And therefore, the planners should argue and tell that you don't have a scarcity of money. Why are you not spending on health and infrastructure, which is going to be beneficial in the long run? Because your manpower would be healthy. You will be more productive. Cities will become much more productive once our workforce are healthy. And then in pandemic, half of the workforce were driven away from the city. Whereas the main function of the city is to attract workforce participation, because workforce participation in urban area is going to be larger than rural area. And therefore, we need to take care of those migrant workers, which we city failed, because there's no provision. And that's one argument I should have put it here also, because if you can't hold your workforce, what is that urban planning is to do?
There is an interesting
primarily
question.
People come for work in the city, primarily. Entertainment becomes the subset demands of work. Once you come, you settle down, you demand house, and then you demand your entertainment facility, public parks, open grounds, and other things, hospitals, schools, later on. First, you need workplace. Yes.
I think
Anything
there is
else? There is another 1 lakh population. Acha, 0.23 planners for 1 lakh population. Okay, is that sufficient for a fastly urbanizing India? Even Nigeria has 1. I can't agree more than you, Parvati. Yes, there is a shortage of planners in India, I think, and I can see the problem here is that the employability is a problem, because once you become a planner, there is a immediate absorption is not so high, because planners are being substituted by management graduates and other engineers and architects and other professionals. So there is a substitute employment, because wherever there is a need of planner, they can hire engineer and do the job. So, that awareness is not there. Therefore, the employability is an issue, and therefore people do not come to these particular professions. And there is a dearth of planning schools in India also. In a country of 1.4 billion, I would say, almost China. China has 100 planning schools. India has only 25 or 30, 31. Both public and private put together. And half of them are not producing even 30 or 40 planners per year, I would say. That me and Ajit have been working on this planning education. That's how this question is also, helping me to recapitulate and tell you. So there is a need for, cities of engines growth, but where are those planners? So there has to be a special category of manpower, planners, wing, or there should be a planning act so that every city should have one planner. We don't have, Parvati, we don't have 8,000 odd cities. We don't have 8,000 planner in India as of today, registered planner, including me. We don't have. And therefore, your Nigeria case is quite valid. Yes, it's quite valid.
And not just that, you were talking about that GIS, use of GIS and special technology here. Right, the stakeholdership of data especially GIS data. There was when JNNURM came into power in the initial stages, there was a huge run to map every household for property taxation related things. Now, this, if it could have been connected with the population data of individual household, I think it would have been easier to address this kind of a scenario. Right, people would have maybe there might have been a little bit of privacy loss, but still then it would have helped a lot in probably recovering from these kind of pandemics, right?
True, yes. I didn't get your point, Gopi. What was that?
The thing is that we have a lot of data already available in the form of property tax related household level mapping has been done, right? But this data is not connected with the population data of individual households, right? Now, how many numbers are there? How many what you call maybe age wise or different categories it could have been attached, and it could have been used by the health centers in each ward, right? So that they can easily keep track, right? Who is vaccinated, who is not vaccinated, or who has been, who is positive, who is not positive, etc. So this kind of data sharing doesn't happen. A lot of stakeholdership is there still on data, and that really creates a lot of issues. So common database for such kind of things, wherein maybe this kind of situation may also lead to a little bit of privacy loss, because people data will be available with an authority or with an organization, but still then I think it will be a safer thing to have such kind of data, right?
Yes, yes. I think the data collection mechanisms are there in India. My problem is that we can't visualize the use and usability of this data, and therefore we neglect. That is one thing. Second thing is that the grossly underreported cases are there. You're collecting data, but you're not collecting correctly the way it has to be collected. And therefore, planning decisions are going to be really, difficult. And if you don't have the proper data and all those things. So therefore, I think data-driven, evidence-based decision-making is going to be a bigger issue, particularly in this pandemic, Otherwise, everything will fall short or you overestimate. These two things are going to be happen. And in either case, you're not meeting the target. So that's the biggest challenge.
One thing that I have noticed that my own PHC, right, it should have given vaccination for the people within that locality, right? The wards for which it is supposed to serve. But people do registrations from far away, 25 kilometers, away from Calicut city, come and take the vaccination and go back, right? So what happens is that the local population is deprived of vaccination. So because of this online single window registration process. So if such kind of vaccination programs are driven at PHC level, right, with local populations being addressed directly, I think we would have been able to develop or provide a better result in this case.
Yeah, that's true. That's true. That we have been doing it, schooling system, neighborhood, so if you belong to this neighborhood, you have to go to this school only. Therefore, that system will also work in PHC, UHC, because you go walk in because you belong to this hinterland of this PHC. So they have to, cater to your needs. But then this, the technological drawback, you can sit from anywhere and you have access of travel. So you go wherever there's a dose available. Because of the hesitancy, also some of the centers are having quite a good number of doses. So in order to utilize, these things are going to be there. But the best way to do it neighborhood level so that, you're ensured. But then the planning has to be done. Each PSC should have sufficient amount of vaccines every day delivered to them, I found in Ahmedabad, in my neighborhood, my first dose was in UHC Urban Health Center. Quite effectively done, no registration online. I just walked in and they said, okay, fine, how many without registration and how many with registration online. And they separated the two lots. And therefore, the major procedural delay was there. Those with did not register, and less procedure delay with those who have registered. So they're quick. So their queue was going quite fast. And ours a little slow because the verification of Aadhaar card and other things happened. And they're all doing on a smartphone. There was no system. There's no laptop there. And they could manage with this system. So I think that hybrid things is better rather than relying on one technology-driven things. If your cyber network fails for an hour, you can't do then anything. So therefore, these are some of the things, since we have not that robust 5G or 6G technology, these delays are going to be there. But yes, I'm happy that these UHCs are put in action for COVID thing. And I think I could see the, staffs and their interaction with the COVID patients and non-COVID patients are improving slowly and slowly. That is there. But still, I would say, if you do health planning separately and urban planning separately, and that's my conclusion for this, lecture, it's not going to help. These two professionals need to come together. And therefore, it gives me another idea of including the, health professional in urban planning curriculum, urban planning courses. We don't have any medical practitioners coming to study urban planning. We don't have. Whereas if you look at Europe and Australia and others, it is open for public health professionals also. Urban planning profession is open for public health professionals. So, and if the health experts are already a planner, you can look at the impact. They can manage it quite well. So those are some of the crucial bottlenecks in India. We should.
I think there is one more
somebody written, Prashant. I'm not sure you want my email ID or you want the journals. I think the source, if I can share the PPT with Professor Gobind and they can circulate you. It is online. This is online. Not Jamia. I think it is from Aligarh Muslim University. That's what you're asking. The research paper that I have shown here.
No, sorry, I'm using my father's ID right now, so that's fine.
That's okay. What is your name?
Sanjay.
Okay, yeah. So what do you want? Email address for journal? Hello?
Yeah, I'll get him. Maybe I'll just talk to him and find out, right, and get back to you.
Okay.
Okay.
And then
Again,
Parvati
has given some more right. Very interesting. Decentralized planning, as Urban Habitat argues, can work only if the planning goes at community level. Should we have something like Brazil is having as right of the city to make our cities resilient and sustainable?
Yes, Parvati, these are the new buzz, and people are working in this area. Planners are coming up with both pragmatic solutions. Brazil, of course, favelas have been, given attention for community level, but still there are many issues in Brazil also. It has not been as participatory as it can and it be, but to some extent, the problem here in India is that still planning by and large is a top-down. The big cities are in a big way doing top-down planning processes. You look at the Delhi master plan, none of the civil society and NGOs have been invited to comment on it. This is by options that you are inviting. No particular team is involved in the process of discussion. It is done by only single agencies, which is NIU. So therefore, if you rely only on only one agencies, the expert groups are not from different expertise. urban planning is a multidisciplinary, and therefore we need all sorts of actors to prepare the master plan and other things. But hopefully, the planning profession gets more attention. I think communities level intervention would be much visible. We need to change from providers to facilitator attitude. And that's what I've been arguing in all the platforms, that planners should not be, provider. We provide this, we provide, no, you're facilitating. And therefore UN Habitat also, and this is my favorite quote by John Claus, John Claus, earlier executive director of UN Habitat, mayor of Barcelona, is quite famous. He's been to Ahmedabad also. I've seen him saying in one of our conference that the difference between good and bad planning is that the good planning, the bad planning is done by planner, and good planning is done by community. So, therefore, that's his, vision and mission. And after almost 50 years of profession, he comes out this conclusion. There is a lot of, meaning in that. And I agree with him, because if you ignore, and Patrick Giddis already told that without diagnosis, if you are prescribing anything, so without survey, you should not be doing anything in the planning domain. We don't do survey, general. And therefore, these are the major issues. After 100 years of planning education, particularly, we've not been able to, completely doing it at the community level, community-based solutions. So, yeah, okay. This is
with that. That is just an email ID, I think.
Okay, I'll try to send you.
Okay, so with that, we'll conclude this session. I'll just request Ms. Archa, if you are there, to say a vote of thanks.
Okay.
And one more thing I would say before this concludes, I would say geographers, please, you all are geographers, don't underestimate the capacity of geographers. Whether you are planner or not, you can do the same thing. But advantage of being planner is that you get more and more, live projects to handle, and therefore, and it gets immediately accepted and results can be seen. In geography, it takes longer time to, advise and then gets implemented. Planners projects are implemented, and I can see that happening. So I've been part of the, Hyderabad master plan and Patna master plan, and some of the plan getting converted on the ground. So I feel good about it. Okay, we had initial idea and this is coming up. I would suggest that, if one has to, from geography to planning, it's a good transition. I'm one of the example here, so do that. And we're best fit, I would say. We are the best fit in urban planning. So therefore, that's my request. Don't underestimate yourself.
Next
being a geographer.
week we'll have another geographer planner.
Yeah.
Next week we are going to have another geographer planner.
Ah, Ajit is speaking next week.
Yes, yes.
Okay.
And I hope you will join, right?
I will not join because he has not joined today.
No, he was there. He was
He was there.
He was there. He was there. I think left a little while ago. Right? He was there till now.
Okay.
I just wanted him to get involved in the discussion, but I think he just scooted off. Right?
He
So
might have something to do with.
Yes, he's very busy nowadays. So with lots of activities going on, he's making this. I think a lot of training and other project-related things are going on. Right?
Ajit is another, another example of planner. Now he's got that position also. So lots of things for him to, do in Kerala as far as urban governance and planning is concerned. Yes. And nice talking to you people. You people are the great future of this country. I would love to be in the campus, Kerala, as I told earlier, also my destination, favorite destination. So thank you so much for listening to my ideas.
Thank you very much for sparing your time. As you are, I know how busy you are. right? Anyway, let's communicate ourselves through WhatsApp and email further, and I'll call you also later. Thank you. Anyway, I'll just ask Archa to just complete the formalities as such, right? So Archa, if you can deliver the vote of thanks.
Okay. Good evening, everyone. I'm here to present the vote of thanks for today's webinar. I would like to thank our webinar speaker, Dr. Anil Kumar Roy, Associate Professor, Faculty of Planning, Center for Environmental Planning and Technology, Ahmedabad, for enlightening us with his knowledge. Thank you, sir. Today's webinar gave us deep insights into the topic of pandemic and urban planning and gave us lots of information regarding the key concerns, issues, challenges, and the role of urban planning in handling the pandemic. I'm pretty sure that this precious knowledge that Dr. Anil Kumar Roy gave us will definitely help us in our studies in future. Once again, I would like to thank Dr. Anil Kumar Roy on behalf of the Department of Geography for taking out time from his busy schedule and enlightening us with the knowledge. Thank you so much, sir, for the very informative and productive session. I also extend my heartfelt thanks to all the faculty members of the Department of Geography and all the students of the department for paying your attention and participating in the session. Thank you all. I extend my gratitude to research scholars and project staffs of the department and faculty members and students of other universities, colleges, and institutions for their participation. Thank you once again to one and all. With this, the webinar comes to an end and I can now exit the session. Thank you.
Thank you so